Yeah.
Okay, so we shall begin today. It's our fifth discussion on anatomy, and today it's we're going to look at the meninges, the basal cisterns, and ventricles. And it's, as I said, it's going to be purely an anatomical discussion, but I will use clinical examples, so there will be pathology to highlight the anatomical issue we are discussing. So three topics: meninges, basal cisterns, and ventricles. So let's start with meninges. We've been learning about the meninges from our early medical school days, and we know, of course, that you have got the three layers: the dura, the arachnoid, and the pia. Uh, and meninges basically means membranes in Latin, and that's what we are going to see today. Dura, which is the outermost layer, which sort of hugs the inner table of the skull, the endosteum, if you like. It's the thickest layer, followed by the arachnoid, which is a thin spidery layer which suspends the vessels, and the innermost layer, which is the pia, which invests the brain substance, but also other structures. So we have talked about the supratentorial and infratentorial compartment, and we have divided them on basis of tentorium. And tentorium is nothing but a reflection of the dura, which is the pachymeninges. Pachy suggesting thick, and meninges is the thickest meninges. And dura itself has got various components to it, and on a CT scan you'll see the dura, or even on an MR scan, as a thin, linear, hyperdense, uniform thickness structure, and you see it very well on the coronal or in the sagittal plane. On the axial plane it is difficult to see it because very close to the calvarium, the resolution is not good enough, at least on a CT scan. One of the problems, of course, is because the veins are very close. Sometimes the veins can mimic the dura itself, but certainly on the coronal plane, you can see the midline forks, you can see the inferior edge of forks, and then here you can see the tentorium. This patient, of course, has got a hematoma there. Uh, and more laterally, you can see how the tentorium edges towards the petrous bone. The importance, of course, being that these leaflets are not just structures to support the brain, but they house the venous structures. And you've got this superior sagittal sinus here, coming all the way down to the torcula, the straight sinus, but also laterally the transverse sinuses and the petrosal sinuses. The other important concept of dura to understand is it's very complex when it comes to the central skull base surrounding the sphenoid, where it invests the cavernous sinuses with its walls, but also arches over the sella and forms the diaphragma sella. So those are the various bits of dura that we have to try and understand. As I said, the dura itself has it invests the sinuses, and that is because it is composed of two layers. The outer layer, which is along the inner table of the skull vault, is a endosteal layer, and the inner layer, which is closer to the pia, is the meningeal layer. And this layer usually are very close to each other, and it's a potential space. But as you come closer to the sinuses, they split together and form these venous sinuses, which are channels which would drain the blood back to the heart. And these sinuses themselves are not single columns, they are usually trabeculated within themselves. And you sometimes see these pockets of arachnoid granulations which project into them from the arachnoid. And for example, over here, this is a patient who's had the lower end of the midline forks over here. On the left side, you see the leaflet of the tentorium on the but as you see over here, there are the two leaflets of the transverse sinuses with a clot in between. Normally, the tentorium should merge with the transverse sinuses, and the enhancement should be homogeneous. Of course, you need to see the rest of the scan to ensure that this is not arachnoid granulation. But over here, this is a scan consistent with someone who's got venous sinus thrombosis with enhancement of the dural leaflets on either side. So this side and this side, and what we should see normally should be contrast in between, which is what we are seeing here, but not seeing in this areas, suggesting of venous sinus thrombosis, with the caveat being that even arachnoid granulations can mimic. The dura, I know Dr. Siripurupu has talked about brain hemorrhages, and I'm not going to spend much time about the patterns of brain hemorrhages, but it's important to realize that the dura itself is very much adherent to the inner table, and in that space we have the middle meningeal artery. So of course we have got a venous plexus in the epidural space as well, but the venous plexus itself uh, is not as susceptible to trauma as is the artery. And the classical artery, which we learn from our MBBS days and which holds true, is the middle meningeal artery. And it's not a single artery. It's of course a plexus. Because of course it starts as a single artery at the skull base coming from the external carotid artery system, and then it fans out into the anterior, middle, and posterior divisions. And it typically is either the anterior or the middle division, which is traumatized by the skull fractures, leading to this epidural pattern of a hematoma. Uh, classically, it is post-traumatic. The relevance of the veins, of course, is that the veins traverse. The veins are the ones which drain the brain cortex. They are the leptomeningeal vessels. They lie in the subarachnoid plane, and they traverse and pierce through the inner layer of the dura before they enter into the superior sagittal sinus. And this concept here is very important to understand because these are the bridging veins. Of course, there are smaller epidural veins which drain directly from the diploe, from the bone, from the meninges into the sinus, but these cortical veins have to traverse the subarachnoid space and bridge the space before entering into the sinus. And it is the tearing of these veins in elderly people, also in young children, which is responsible for subdural hematomas. These veins are anchored at the level of the superior sagittal sinus, and they are held fairly reasonably firmly at the level of cortex. But when they traverse this space, they are most susceptible to trauma, either because of shaking or when the brain atrophies, as in elderly people, when the brain shifts away from the calvarium and these veins are stretched, and hence responsible for the more susceptible nature of these veins, causing the subdural hematomas, as seen in this example over here, which are typically convex and extend over a much larger area. The terminology to understand in this location, apart from hemorrhage, is bleeding, and when you get is infection. And infection in the epidural space almost always is secondary to infection within the adjacent bone or the sinuses. The sinuses can be the air cells within the mastoids, or they can be the sinuses, the paranasal sinuses. So the spread from these sinuses into the dura can give rise to these classical appearances of empyema or pus, which is really a neurosurgical emergency. So it's very important to identify this. On CT, sometimes it can be difficult because they can be very small, thin films, and that's very useful, especially if you do a diffusion scan or give contrast to identify these small thin layers of empyema, not because of the volume of pus, because the effect that they're going to have on the adjacent brain parenchyma, because it's remember we talked about the venous plexus in the epidural vein, but also the bridging veins, and it is a thrombophlebitis of these venous plexus which is going to cause extensive infarction and ischemia in the underlying brain, and of course spread of infection into the adjacent brain parenchyma itself. Uh, the disease can be focal. Here you have got a classical appearance of a meningioma, but sometimes it can be septal, and for that really we need to give contrast. So this patient has got a cancer in the nasoethmoid, and you may be lucky and you may spot that on a thin section coronal scan, but contrast makes it easier. As soon as we know that the cancer has spread onto the dura, it's a different ball game, and the treatment strategies are much different. So if you suspect meningeal disease, dural disease from the adjacent structures, make sure that you look at the post-contrast sequences in thin sections. Uh, Dr. Siripuru showed you a case, I think last week or maybe the week before last. This patient, if anyone can spot the diagnosis, I'll keep on describing. You can give it the answer in the chat group. Extensive pachymeningeal thickening. This is enhanced scan. You can see the dura which is enhancing. This is the calvarium. This is the dura. This is the brain substance, the CSF spaces. The hyperintense dura over here, and the low-lying tonsils with the brain sagging down appearance. Anyone can suggest what the diagnosis is in the chat group? Give you a few seconds. Yes, I think you have got it absolutely right. This is intracranial hypotension, diffuse pachymeningeal process. Uh, and of course, you don't have to have isolated pachymeningitis or leptomeningitis, leptomeningeal disease. Leptomeninges are pia and arachnoid. Here you have a patient who's got a lymphoma of the skull vault. You can see the abnormal skull vault over here with soft tissue within the scalp, but also in the epidural space. But you can see this finger-like, thread-like extensions into the cortical sulci. Here on the zoomed up pictures, you can see within the sulci, so suggesting involvement of the leptomeningeal surface in this patient. Uh, Next layer, arachnoid suggests spider-like, web-like appearance, and this indeed is a membrane which is not just a thin membrane by itself, but it sends out finger-like thin projections by which it anchors the adjacent brain parenchyma. And within that space lies the blood vessels, classically the leptomeningeal arteries, which are then going to penetrate the surface of the brain and extend into the brain substance itself. And it's very important to recognize these finger-like projections, because when we see a CSF space, it's not just a bland CSF space. It's got small thin membranes which we don't see on a scan, but I'm sure you see it during neurosurgery, which invests the brain substance and anchors it to the adjacent meningeal tissue. And one such, which is classically described, is the Lilliquist membrane. And here is a high resolution picture over here of sagittal T2 sequence. And you can see this membrane which anchors the brain stem, which anchors also the midbrain onto the dorsum aspect of the cella over here. And these membranes are relevant because also they're important for structural support of the brain substance, but they also guide pathology. If you read the literature on aneurysms and aneurysmal disease, you'll realize why in some instances aneurysms project in some direction, why in some instances aneurysms cause bleeding in a particular direction and not the other. And this is related to these arachnoid membranes, these arachnoid webs, which hold structures in a particular direction. Uh, the Arachnoid space we classically know because of the subarachnoid bleed, and that's because the arteries, the leptomeningeal arteries, the branches of the anterior, middle, and posterior cerebral artery lie within that. And of course, the aneurysms arising from them are going to line that space, hence resulting in this classical appearance of subarachnoid hemorrhage with blood within the CSF spaces at the basal cisterns, but also higher up over the convexity. Remember, the sulcal spaces, even though we don't see them here, extend all the way, and that's how the arteries are going to penetrate and supply the brain substance. Finally, the pia, very thin layer, and as I said, it sort of converges. It's an over the brain substance. It will follow all the convexity sulci. It will follow the folia of the cerebellum. Not only that, it will also extend along the nerves and the vessels. I'll show you with some clinical examples in a minute. It is important for the formation of the tila choroidea. We'll come to that a bit later on during the discussion. And finally, along with the ependymal margin, it forms the choroid plexus within the lateral ventricle. So leptomeninges, as we said, is a combination of pia and arachnoid. It is on the surface of the brain. So you can see here, it is on the surface of the dorsal aspect of the midbrain. It is on the surface here of the temporal lobe medially, but it also covers the arteries. And here it is, you can see the enhancement along the middle cerebral artery. This is a patient with tuberculosis. You can see enhancement along the posterior cerebral artery. So this is how leptomeningeal disease not only covers the brain substance, but also covers the arteries and the veins. And here is a patient with leptomeningeal disease surface of the cerebral folia, different patients. Here, this is a contrast enhanced scan. This is a susceptibility weighted image SWI sequence, and this highlights this black tissue on the surface of the brainstem over here anteriorly, darker substance, but also outlining the cerebellar folia. And this patient has superficial siderosis. Uh, and this patient has metastasis from a bronchogenic carcinoma with the folia studded with cancer cells. So this is the importance of doing the appropriate sequences in suspected leptomeningeal disease. Contrast is almost mandatory to look at leptomeningeal disease. Before we move away from the meninges, I just want to spend a few minutes talk about the parasites, not just because we see them during imaging, but it's very important to understand they play a very, very vital role in homeostasis around the brain substance. So you've got the dura and the subarachnoid space over here with the arteries within the subarachnoid space, and as they start penetrating the brain substance, so this is a brain substance, and as they start penetrating the brain substance, they will get covered with a bit of CSF space on either side, and that is basically the perivascular CSF space. And it's not just an indolent CSF space by itself, it is a very dynamic space because it is important to ensure that the nourishment reaches the neuron, but all the toxic substances that are there within the arteries do not cross out, and that is responsible for the integrity of this what we call as the blood brain membrane. And that membrane itself is not just the endothelial cells which surround with the lumen of the artery, but you've got the footplates of the astrocytes, which are absolutely essential in maintaining the integrity of these perivascular spaces and the blood-brain membrane. And a lot of research is going on into see what alters the permeability of the blood-brain membrane, or how you can alter it to get delivery of the drugs so that they can reach the areas of tumor which gets altered because of increased permeability. Also, it's important to realize that some of these cells contain receptors, one of which is aquaporin 4. And if you have got any neurologists amongst us, they would know that the abnormality of this gene, of this protein, is going to be responsible for inflammation in disorders like the neuromyelitis optica. Important to understand this concept of perivascular spaces. We'll just see some examples of pathology around here. So again, just to remind, the perivascular space is a space surrounding a small arteriole, and it is surrounded by CSF. And this is a very, very common appearance in the basal ganglia. Sometimes they can be small, pinpoint, but sometimes they can be as large as this and can be mistaken for a lacunar stroke. And here are some examples of pathology which can occur as they penetrate from the CSF spaces into the brain substance. So you can understand. So this is just a pictorial representation. These are the this is the carotid artery. This is the middle cerebral artery with the perforating which can track along the middle cerebral arteries into the deep nuclei. And here is one example over here of a patient with HIV who's got disease within the basal ganglia. Here, this is a patient with cryptococcal disease or cryptococcomas. This is another patient who's got disease at the level of the basal cisterns over here. So the disease is at this level over here, and it is causing inflammation surrounding these arteries, resulting in this infarction, as you see on the diffusion scan. So this is basically a disease along the penetrating arteries, affecting the perivascular space, inflammation causing infarction. So this is tuberculosis. So just a concept to understand about this perforator artery disease along perivascular space. So that was a brief discussion on the meninges and the anatomical principles, but to highlight some of the pathological conditions. We'll move on to cisterns. It's a very big topic, but we'll try and condense it to some relevant cisterns that we see in day-to-day practice. What is a cistern? Cistern is basically CSF spaces, and this is what cisterns look like. This is a cave here, a man-made cave, and you can see it has got various septations, and the septations are basically the arachnoid septae that we see that I showed earlier on, and these are CSF fluid-filled spaces. And though there are septations, will communicate with each other and are finally in communication with the venous system. It's a space between the pia and the arachnoid. So you can see the cisterns on CSF on CT scan, and as I said, they contain CSF, so they will be low density, as are the sulci over here. We don't call these sulci as cisterns. Cisterns are more prominent CSF spaces. So over here As you come more closer to the skull base, you'll see a more prominent CSF space at the skull base, and this is the Sylvian cistern or the Sylvian fissure as we call it, which continues. And we talked about this in our supratentorial discussion when we talked about the superficial and the deep aspect of the Sylvian fissure. And then another cistern over here, which is just above the sella turcica, the suprasellar cistern. And we'll look at all the cisterns now during the discussion. What I would like to highlight as a very important concept is that the cisterns are not just CSF floating within them spaces. They contain CSF, but not only CSF, they contain very important structures, and those are the structures which we'll try and look at now. They contain arteries, they contain veins, and they contain nerves. And the cisterns are named based on the location to the adjacent structure. So let's start with the supratentorial compartment. One of the most important structure is the suprasellar. So here we have the sella turcica over here. If you understand, this is the back of the sphenoid sinus. Over here you can see the sphenoid sinus, the small space in between the sphenoid sinus at the back, and the clinoid process over here. That's the sella deep in here. And as you start coming up over here, this is the space just the top of the dorsum, and just over the dorsum, this pentagonal shape is the sellar cistern. It's got this classical pentagonal shape, and it contains structures, and you can just about start seeing the structures. There is a small dot right at the back. We are at the back end of the suprasellar structures in front of the pons actually, and that's the basilar artery, which is behind the dorsum over here. At the back is the is the pituitary infundibulum. Then there are small dots on either side over here, and we'll look at them again in detail on MR scan. And these are the internal carotid arteries. So the suprasellar cistern, immediately on a CT scan, you have seen there is the pituitary infundibulum. You've got internal carotid arteries, and right at the back, in front of the pons, in the prepontine system.
Dr. Herwadkar.
Another structure to show. Yeah. You can hear.
I think there's a bit of lag with the slide and the stream itself. If we could maybe turn off the.
Are you seeing the suppression?
Yes, but also the voice is breaking, so maybe the internet connection is a bit slow.
Okay.
If we switch off the camera, maybe that would help.
Okay, let's do that. Yeah. Okay, let me get part of that. Just come out of this. Okay, shall we try that?
Yes.
Yeah. Okay, let's try. Thank you for that. Okay, so coming back to a suprasellar cistern, so we'll look at the details of the suprasellar cistern in a minute. The other thing to see on this slides is the suprasellar cistern. As I said, CSF is not just located in one space; they are communication with each other. So the suprasellar cistern laterally communicates with the Sylvian cistern over here, Sylvian fissure laterally. Anteriorly, you've got the anterior interhemispheric fissure. More posteriorly is the prepontine cistern. So we look at these cisterns in turn. So I hope you're seeing the suprasellar cistern slide on the on now. So you've got a sagittal pictorial representation with a MR picture over here in the sagittal plane, in the axial plane, and in the coronal plane. So as I said earlier on, the suprasellar cistern is the one which is above the sella. So you've got the sella over here with the pituitary gland residing within the sella, the dorsum sella, and the cistern itself is this space above the sella itself, which is going to be this space over here. Again, the anatomy, just to remind us, this is the pituitary gland, this is the sella, the suprasellar cistern over here, the brainstem, and the structure over here along, which runs kind of parallel, is the floor of the third ventricle. So the third ventricle is all of this space over here. So just to look at it on an MR scan, this is what it looks like. We've got the sphenoid sinus with the air within it, the pituitary gland, the suprasellar cistern is going to be the structure above the sella itself, all of this structure over here. It's a very small space, as you can see, because the floor of the third ventricle is the roof of the supracella cistern. And this is again on a high resolution T2, the sphenoid sinus, a small pituitary gland, the pituitary infundibulum, and this is the superior aspect of the dorsum of the cella, and any structure above that is going to be the supracellular cistern, with this representing the floor of the third ventricle. So in other words, the floor of the third ventricle is actually the supracellular cistern. And you can imagine it contains the pituitary infundibulum. It contains this structure, which is the optic chiasm over here, and I'll show you that in an axial. So what we are seeing here, the optic chiasm is over here in the midline. So the optic nerves come from each side. These are the optic nerves, and this is the chiasm, and this is what we are seeing here on the sagittal image. So this is in the supracellular cistern over here, and just behind the optic chiasm is the pituitary infundibulum, which is this small rounded structure over here. This is the pituitary infundibulum. And that forms the floor of the third ventricle. And in fact, you can see the third ventricle itself sends small recesses into the optic chiasm and to the pituitary infundibulum. And we'll look at that a bit later on as well. So those are the structures within the supracellular cistern. We talked about the other structures, the carotid arteries. Here you've got the internal carotid arteries with the anterior and the proximal aspect of the middle cerebral arteries. Again, here on a coronal picture, you've got the carotid termination, which is still part of the supracellular cistern, with the proximal ACA just above the optic chiasm and the proximal MCA. So those are the important structures residing within the supracellular cistern. The other important structure are the much smaller arteries, the anterior choroidal and the posterior communicating artery. This is a CT angiogram. I hope you can see that. There is not much lag, I hope. And this is a high resolution CIS sequence or a fiesta sequence to highlight the structures within the supracellular cistern. So just to show you again, this is the supracellular cistern, the bright CSF field structure, communicating laterally with the Sylvian fissure, communicating anteriorly with the anterior interhemispheric cistern or fissure, and posteriorly with the prepontine cistern over here. So the supracellular cistern is that portion over here, and the artery to highlight is a small tiny artery here which courses posteriorly, and another artery here which courses posteriorly, and these two arteries sort of go posteriorly, one which goes more laterally subsequently, which becomes a choroidal artery, and the one which goes and joins the posterior cerebral artery, which is a posterior communicating artery. And these are the two arteries that I'm trying to show over here, the posterior communicating artery and the more lateral, the choroidal artery, which enters the choroidal fissure and supplies the choroid plexus in the temporal horn. We could discuss a bit more about the anatomy of the cella next week. But it's very important. If I were to just go back one slide or the two over here, I hope you're seeing my slide of the supracellular cistern, is to look at this optic chiasm over here. And it's very important to understand where the pathology arises to look at this optic chiasm. So if I were to just skip these two slides, I hope you're seeing this slide with the cellular tumor over here, the pituitary adenoma, a more complex appearing adenoma. But the important thing is to look at this stretched optic chiasm. If you see the chiasm which is stretched superiorly, then we know this disease is arising from below the chiasm, and almost certainly it is a pituitary disease. But if the chiasm is actually displaced inferiorly, as in this case over here, and by this lump which arises from the left side of the hypothalamus, then we know this is actually arising not from the pituitary but from the hypothalamic. When the tumor becomes quite big, sometimes it is difficult to understand whether it is coming from the cella or a supracellular region. But in this case, if you can identify the optic chiasm, it helps us to determine whether it is arising from the cella itself or whether it is arising from the chiasm. As I said earlier on, we have got the extensions of the supracellular cistern. We had the lateral extension into the Sylvian cistern, Sylvian fissure, and the contained middle cerebral artery within them. This is a CT angiogram over here. You can see the middle cerebral artery reaching out, and the middle cerebral artery and its branches. And in this patient, you can see that there is abrupt cutoff of this artery because there is a thrombus. This is a CT angiogram in a patient with stroke. You can see the occlusion within the middle cerebral artery lying within this sylvian cistern, and this is a hyperdense appearance of the artery on a plain scan because they have got a fresh thrombus, a clot within it. And this cistern more superficially, so this was a deep aspect, this is a more superficial aspect of the sylvian cistern, and you can see the clot actually within the branches of the MCA. You can see a normal enhancement within the branch, and just medial to that, the non-enhancing slightly enlarged dot of the branch of the MCA. Uh, this is easy for the neurosurgeons. You can see the anterior extension of the suprasellar cistern is into the anterior interhemispheric fissure, and this patient has got an aneurysm uh, in the anterior communicating artery, and this is another patient with a big lump arising at the anterior skull base, a meningioma of the cribriform plate. So from the suprasellar cistern, we now move back. Let's go into the posterior fossa and see the cisterns at the back end of the posterior fossa. So we'll again start with the suprasellar cistern over here, which was that sort of a pentagonal shaped cistern, which was in front of the pons. This is the dorsum, this is the pons, and we are just up. So this is the sella here. So this is the cistern just in above the sella. This is a suprasellar cistern. So the cistern which directly leads into the brainstem from the suprasellar cistern is the interpeduncular cistern, because these are the cerebral peduncles. So this is the interpeduncular cistern. As you go more inferiorly, the interpeduncular cistern leads into the prepontine cistern. As you go more inferiorly, the prepontine cistern leads into the cerebellopontine angle cistern, and the more inferiorly we are at the level of medulla, and these become the perimedullary cisterns. So this is how you sort of try and understand the cisternal anatomy, starting from the suprasellar cistern, identifying it, and then its extensions anteriorly, laterally, more posteriorly, and then inferiorly. Now let's look at these cisterns in turn and what do they contain. As I said, the suprasellar cistern is above the sella over here. We looked at these structures within the suprasellar cistern. The one structure which I didn't mention earlier on, because it is just behind, it comes within the almost within the confines of the posterior fossa or at the tentorial edge, is the mammillary body over here. So here we are again in the suprasellar region, the optic chiasm, the small pituitary infundibulum, the basilar termination, the posterior cerebellar artery branches, the small posterior communicating artery, which starts from the carotid and connects itself to the posterior cerebral artery over here. So these are all parts of the suprasellar cistern. The structure which is very important within the interpeduncular cistern is the third nerve, or the oculomotor nerve, and that starts somewhere from the periaqueductal region over here, courses through the midbrain, and comes out along the medial aspect of the interpeduncular cistern and reaches towards the cavernous sinus and the superior orbital fissure. So you can see these nerves on these high resolution T2 images. And just to show you a pathological condition, this patient has got this lump within the right side of the temporal lobe, and you learned last maybe a couple of weeks ago about the herniations of the brain, and this is the medial most part of the temporal lobe. This is the temporal lobe. You can see the swelling of the temporal lobe, and you can see on this zoomed up picture over here of the same scan over here, this is the uncus which is compressing on the oculomotor nerve in the coronal plane. So we are in the coronal plane. You've got the basilar termination over here, the posterior cerebral artery, the superior cerebellar artery, and between them here on the normal side, the oculomotor nerve at that level before it has reached the cavernous sinus. So this is that same oculomotor nerve, and you can see its intimate relationship to the uncus, but also to the posterior cerebral artery, the basilar termination, and the superior cerebellar artery, but also the posterior communicating artery. And you can see how the aneurysms in this location can affect the nerve. But in this patient, you've got the herniation, which is compressing the nerve, and you will have heard about the clinical presentation with dilatation of the pupil. Uh, uh, we are now on the slide of the perimesencephalic cistern. So the perimesencephalic is basically a broad term which talks about all the systems surrounding the mesencephalon. So we started with the interpeduncular system, then these are the cerebral peduncles or the crus cerebri, also they're called as, and this becomes the uh, uh, crus fissure or the cistern, crural cistern, and as it arches more laterally, the crural cistern becomes the ambient cistern over here, but they are quite often used interchangeably. And the ambient cistern goes all the way back up to the level of the colliculi. These are the colliculi of the midbrain, these two structures here right at the back. And then these become the collicular cistern, or also called as the quadrigeminal plate, because the four structures at the back end, the four colliculi, the superior and inferior, form the quadrigeminal plate, and these are called as, this is called as a quadrigeminal plate system. So the supracellular system, the interpeduncular system, the crural system, ambient system, and the quadrigeminal plate system. And you would have seen in your clinical experience these perimesencephalic bleeds, which are innocuous because they don't tend to rebleed, they don't often find aneurysms, and you would see them in about 10 to 15% of cases. And there is blood predominantly seen within the interpeduncular system, but also extends along the crural systems into the ambient system. And the structure which resides in that location over here, we saw the posterior cerebral artery, but also a very important venous structure, which is the basal vein of Rosenthal, which is a venous structure right at the base of the brain, hence the name, the basal vein of Rosenthal, which curves around the brainstem. And we look at the detailed anatomy of this vein in our discussion on the venous anatomy, but this is just to show you a pictorial representation. This dense is the artery here, and this dense is the artery, the posterior cerebral. But you can see medial to the uncus, within this ambient system, is this venous structure which leads towards the galenic venous system. This this is the basal vein of Rosenthal. Uh, the ambient system. So as I said, the ambient system is kind of the continuation of the crural system. So around here, and this is the area we are looking at, the ambient system. Very, very important, because I've shown you one example, the basal vein and the posterior cerebral artery. And this is the area over here we are looking at, the posterior cerebral artery and the basal vein of Rosenthal here on the zoomed up picture. But another important structure to highlight, and this is a pictorial representation, this is a coronal picture of the left side, so around about this side over here, if you were to imagine. So this is going to be the adjacent to the brainstem, which is this space over here. And you can see the temporal lobe, the temporal horn over there, the temporal horn, and the structure underneath, which is a hippocampus over here, the hippocampus, and that's the ambient system, which is here. And from here, you get the branches of the posterior cerebral artery, which pierce this space over here called as a choroidal fissure. And this is a choroidal fissure over here, this small space over here, through which the branches enter and supply the choroid plexus of the temporal horn. And this anatomy is extremely important for clinicians working around this area to understand, because not only have you got these arteries which supply the choroid fissure and the temporal horn, but also the optic tract is just about this level over here. So very, very crucial to understand this anatomy. And finally, so we have started from the supracellular system, we have worked our way backwards, we are coming towards this quadrigeminal plate system or the tectal plate system, which is behind the tectal plate, behind the brainstem over here at the level of the midbrain, a very small CSF space. And of course, you're going to have the branches of the posterior cerebral artery, which will supply the tectum at this level. One nerve which we get right at the back end, in fact, it is the only nerve which exits from the dorsal surface of the brainstem, is the trochlear nerve, which you can see. It's the thinnest nerve and most difficult to visualize on an MR scan. And these are two different conditions which sort of protrude into the tectal plate, and you can understand the structures from here are very likely to be related to the tectal plate itself. So here we have got a T1 sequence with a bright structure over here. This is a tectal plate lipoma. You would have to do other sequences to confirm that. And this is a gradient echo sequence showing the markedly low signal of a cavernous of a cavernoma arising from the tectal plate. Moving on, as the name suggests in front of the pons. So we have now worked our way back from the suprasellar cistern into the prepontine cistern. We are not operating at the perimesencephalic level. We are operating at this level now. The section in front of the pons, the section behind the clivus, which contains the basilar artery, shown here in the sagittal plane on the CT angiogram and shown here in the coronal plane. Against the anatomy is the same. You've got a basilar artery, basilar termination, posterior cerebral artery, the superior cerebellar artery, and remember the small oculomotor nerve which resides in that location. But this the prepontine cistern is in this location over here. And again, this is a pathological condition where the patient has presented with sudden onset loss of consciousness, and you have got a patient with a CT scan, plain scan, which shows the hyperdense appearance. We saw the hyperdense appearance of the middle cerebral artery. This is the hyperdense appearance of the basilar artery, suggesting a clot within the artery. And this is a CT angiogram. And just to compare, you should get normal opacification of the artery right to the termination, whilst this patient has got a clot within the basilar artery. We have looked at the artery. Let's look at the nerves within the prepontine cistern. The one typical nerve that we see all the time, the thickest of the nerve, the largest, is the trigeminal nerve, because it has got a large nucleus here which supplies the motor and the sensory components, traverses through this prepontine cistern before it reaches the cavernous sinus over here. This is the cavernous sinus on the contrast enhanced scan. So the nerve starts somewhere from here, goes through the prepontine cistern into the Meckel's cave, and then reaches the cavernous sinus. So here is that same nerve exiting out from the brainstem into the Meckel's cave. Here, this Meckel's cave is bright CSF containing. This Meckel's cave is also bright CSF containing. And this patient has got a tumor over here because the tumor has started from the trigeminal nerve, and this patient has got a schwannoma. If anyone can spot the diagnosis and want to give the answer on the chat, this is a time of flight MR angiogram. This is the internal carotid artery. Remember, this is the cavernous segment of the internal carotid artery. This is the basilar artery, and this artery is actually joining these two arteries. It's not at the level of the posterior communicating. Remember, we are behind the clivus. It is much below the level of the posterior communicating artery. So if you can know the diagnosis, if you let us know, perfect. Hannah has got it right. This is the persistent trigeminal as well as upper nerve. Okay. The other nerve, apart from trigeminal, so this is still the trigeminal nerve over here. You can see the displacement of the pons away from the back of the clivus here. Very difficult to see the pathology, and again, to show the importance of using the right sequences, this is a diffusion sequence, and suddenly you realize that this structure here, though it looks CSF like on T2, though it looks CSF like on T1, on diffusion it is a restriction. So this is not CSF. This is anyone know what the diagnosis is? For want of time, I will continue. Epidermoid within the prepontine cistern. And finally, if you know the diagnosis, carry on and type the diagnosis. But just to highlight the importance, this is a patient with the abducens nerve over here, arising just below, but medial to the trigeminal nerve. We are above the level of the internal auditory canal. It starts below, but it climbs up because finally it has to reach the orbit and supply the lateral rectus, and it does so by penetrating the petrous apex through a small channel called as Doloro's canal, and so it sort of runs in that direction, supero-inferiorly, and that's where it's most vulnerable, at the level of the petrous apex. And this patient, if anyone knows the diagnosis, please type it away, has got disease within the petrous bone. You can see the mastoid hair cells are well pneumatized. Poorly pneumatized mastoid hair cells, the petrous apex, which is well pneumatized, is poorly pneumatized. You can see on this post contrast scan there is enhancement at the surface of the petrous apex over here, enhancement on the surface over here, and this patient has got Gradinego syndrome. Perfect. I've got awake audience today. We move our emphasis a bit lower down now. We have finished the prepontine. We are coming into the cerebellopontine angle cistern, probably the most popular cistern because we tend to get a fair amount of pathology in this area that can be easily identified. And again, to look at the cisterns, you have realized I'm using this heavily titulated sequence, and that's another point to emphasize, that if you want to look at cisternal anatomy and pathology, we have to ensure we look at these heavily titulated sequence. And you can see that in this patient, does it contain? It contains the nerves which arise from the vestibular and the cochlear nuclei from the dorsal aspect of the brain over here, the medulla over here, and it traverses the cerebellopontine angle system. And these are the nerve complexes which travel and supply the cochlea and the vestibule as well as the semicircular canal. So these are the vestibulocochlear nerve apparatus. And this section of a CT scan is to show you another structure, very important structure, and this is the facial nerve canal travel and it contains a facial nerve. So the CP angle system not only contains the seventh, eighth nerve complex, the eighth vestibular and cochlear nerve, but also the seventh nerve. So this complex is a seventh, eighth nerve complex, and the artery, which characteristically you see in this location, a loop-like artery, which can sometimes actually extend into the internal auditory canal, is the labyrinthine artery, which is a branch of the anterior inferior cerebellar artery. We'll talk about these arteries in more detail as we look at the arterial anatomy. So the cerebellopontine angle system, we have seen the seventh, eighth nerve complex and the ICA and its branches. And the classical tumors, I'm sure you all have all seen here the classical appearance of a vestibular schwannoma protruding into the cerebellopontine angle system, going along the length of the internal auditory canal over here. High resolution T2 showing the same as a filling defect. Normally you should see the CSF with the seventh and eighth nerves beautifully along with the signal within the cochlea. Here you have lost the signal within the cochlea. You have got the signal within the vestibule and the horizontal semicircular canal, but you have lost the signal on the right side. You have got a normal signal, you have lost the signal, and on this post contrast sequence you can see that there is enhancement within the cochlea as well. The cochlea normally does not enhance, so this tumor certainly is involving the cochlea, suggesting that it is probably either cochlear invasion by the tumor or a cochlear schwannoma itself. And just to look at another schwannoma, this is a facial nerve schwannoma. This is normal enhancement of the facial nerve, thin linear enhancement that we see. And this patient has got a tumor round about this location, which is a geniculate ganglion. So this is a facial schwannoma, even though there is a component of the tumor which protrudes into the cerebellopontine angle region. And again, the ubiquitous tumor of the skull base and the skull wall, a meningioma of the CP angle system extending into the internal auditory canal. We move further lower down, we've got the perimedullary systems over here. And these systems are surrounding the medulla. We've got a premedullary and the perimedullary, and then the retromedullary system over here, which kind of continues with the fourth ventricle itself. The structures within them, if you've got the vertebral artery, and we'll look at that in a minute, and the important artery is the pica, the posterior inferior cerebellar artery, and then we have got the complex nerves, the 9th, 10th, 11th, and also the 12th nerve. And it's very difficult to tease out the 9th, 10th, 11th nerve from each other, except that we have to try and understand that they lead themselves into the glossopharyngeal or the jugular foramen. So if you see a nerve complex which leads itself towards a jugular foramen, then it is going to be the 9, 10, 11 complex over here. And this is just to show you the jugular bulb with the enhancement of the within it, and the jugular vein and the sigmoid sinus leading on towards it. So these are the perimedullary systems with the 9, 10, 11th nerve. But also we know that the hypoglossal nerve, which does not enter into the jugular foramen, but enters the hypoglossal canal. And this is the CT scan of a different patient to show the anatomy. So this is the medulla oblongata over here, a thin fiber-like extension leading out behind the vertebral artery through a very small area called as a retro-olivary sulcus. And we'll look at that in detail when we talk about the anatomy of the nerves, which leads out from the ventrolateral surface of the medulla, goes out through the hypoglossal canal over here, which is that structure over here, and supplies the tongue and its and the rest. So this is a patient. This is the normal appearances of the hypoglossal canal within the perimedullary system, and we have seen the vertebral artery itself as well. The other artery to note here is the pica, which is a posterior inferior cerebellar artery, and this is the patient with a hypoglossal palsy because of tumor, a meningioma affecting the hypoglossal canal, causing the deviation of the tongue. The vertebral artery, again, here you see on either side the pica, which arises from the vertebral artery, which has this characteristic appearance here. I've shown it on the sagittal picture over here. It starts in front of the brainstem, premedullary segment, lateral medullary segment, retromedullary segment, and then this classical tonsillar loop, and then and then roundabout here it divides into the hemispheric division and the Wormian division. So here you have again the pica artery starting over here. You don't really see the pica, but you just about see a branch of the pica coming from here. This is going to be the hemispheric division. So the pica is going to swing around the lateral medullary segment, give pass through the foramen of Luschka. This is here the fourth ventricle, and supply the vermis, the Wormian segment, and then the hemispheric segment more laterally. And this is the more lateral hemispheric segment, and these are the Wormian branches of the pica supplying the cerebellar vermis. And just to show you an example over here, you've got a patient who's got a hematoma at the level of cerebellar vermis, and you can see the hematoma. If you see a hematoma in the vermis, I think it's a duty that we look at the pica, because we are used to seeing the at the vessels within the big basal cisterns, but the pica is the artery which kind of penetrates and comes very close to the ventricle, and this patient has a small aneurysm over here, and this is just to show the angiogram with a tiny aneurysm arising from the Wormian branch of pica. And finally, before we leave the perimedullary resistance, here you have got a patient who's got an infarct, Wallenberg syndrome of the posterolateral medulla, and this is a dissection of the vertebral artery giving rise to this infarction affecting the posterolateral medulla. So again, a pictorial representation of the vertebral artery. So you've got the vertebral arteries, two sides joining together to form the basilar artery, and this vertebral artery will supply to the posterolateral aspect of the medulla, but also the pica will do the same. So infarcts of this area, you have to carefully look at the vertebral artery and the pica. We've got another 10 minutes, perhaps 15 minutes to look at the ventricles. Uh, uh, if we look at them in turn, we've got the lateral, the third, and the fourth ventricle, and finally continuing as a central canal of the medulla oblongata and the spinal cord. Just to revise our anatomy of the embryology, if you like, we remember we talked about, when we did our embryology talk, we talked about the prosencephalon, the mesencephalon, and the rhombencephalon, which are derivatives of the neural tube after it has closed. The prosencephalon is the one of the forebrain, the mesencephalon for the midbrain, and the rhombencephalon for the hindbrain. The prosencephalon itself will then divide into the telencephalon and the diencephalon over here. And it's again, the reason to highlight this is because the optic nerves are derivatives of the diencephalon. The diencephalon itself is going to form the thalamus itself. And it's important to realize that the optic nerves themselves, though they start from the orbits, are relay at the level of the thalamus, at the level of the lateral geniculate body, and the optic nerves themselves are continuation, and hence we see the CSF surrounding them, which is continuation of the CSF. So these optic nerves are actually derivatives. They are not part of the peripheral nervous system, though we call them as nerves, but they are actually continuation of the central nervous system and can get affected with similar disorders like neuromyelitis optica, like multiple sclerosis, which affect the central nervous system. And the other thing to identify, to mention is these optic nerves are derivatives of the diencephalon, is that any metameric syndrome which affects the diencephalon can also affect the optic nerves. So this is a concept that you have to try and understand, but we will cover in a little bit more detail when we talk about the arterial anatomy. So these syndromes are called as CAMS, cerebral arterial metameric syndromes. So if you get a hemangioma, or if you get an AVM within the forebrain, it's important to look at the nose and the orbits more carefully. Similarly, if you see a orbital hemangioma, it's important to look at the brain, so on and so forth. So let's look at the anatomy of the ventricles. Okay, so the ventricles usually very well defined on T2-weighted sequence because they're bright. They've got a very smooth margin. You don't really see the cellular layers, but they've got a very sharp, smooth margin over there. And you've seen the lateral ventricles here on either side. They have got a midline septum. The third ventricle is the unpaired ventricle. The lateral ventricles are paired on either side, and then the occipital horns going all the way back. We'll look at the midline anatomy of the third ventricle a bit later on, but this is just to show you that the lateral ventricles, which are these, are above the level of the third ventricles over there. And the third ventricle itself, which is here in the midline, leads to the aqueduct and fourth ventricle. The ventricle has to be nice and smooth and thin, but here in this you can see that the thin layer has become much thicker because there is abnormality. And if you are suspecting ependymal abnormality, like we saw in the leptomeningeal abnormality. Contrast, you can highlight this ependymal abnormality in this patient who's HIV and has cytomegalovirus infection. Okay, so the ventricles, we have started with the lateral ventricle. We have said there are two frontal horns separated by the midline septum in the middle, the third ventricle. So this is just to show you the CT anatomy. The third ventricle going inferiorly, the inferior recess. On either side of the inferior recess is the subthalamic or the hypothalamic region. We look at that carefully on an MR scan. And then the third ventricle extending posteriorly into the aqueduct, and the aqueduct reaching into the fourth ventricle, and the fourth ventricle communicating through the CSF spaces uh, in the perimedullary resistance through the foramen of Luschka and the foramen of Magendie, here containing blood within them. Normally they should not contain blood. So this is the foramen of Luschka more laterally and Magendie medially, which leads into one cistern which we didn't talk about, is a cisterna magna right at the back. So here we have the lateral ventricles over here, again the frontal horns, the occipital horns at the back, and the temporal horns, which are around about over here. And it's difficult to understand how the continuation of the temporal horns with the body, but they communicate roundabout in a very arc-like fashion through an area called as the atrium of the lateral ventricles. The structures of the lateral ventricle themselves, there's not much to talk about them. We'll talk about the foramen of Monroe in detail further down the line. But the one area which again we have talked about is the temporal horn region. The temporal horn, as I said, communicates with the lateral ventricle through the atria, but it also communicates with the ambient system through the choroidal fissure over here. And the importance of the temporal horn is, of course, in its roof lies the optic tract, and along its floor lies the hippocampus. And along its deepest aspects are the posterior cerebral artery and its branches, and the basal vein of Rosenthal and its branches. Periventricular disease, neurologists amongst us should know the diagnosis. So the disease which can affect the ventricles, especially along the venous channels, and this is a patient with multiple sclerosis. So let's look at the third ventricle. We have talked about the third ventricle. It is formed in between the two lateral, the two thalami. It's slit-like structure over here communicates anteriorly with the foramen of Monroe on either side. This very small slit-like foramen of Monroe, and there is a midline septum which sort of separates the two frontal horns. And these small rounded areas here on either side are the columns of fornix, which we'll look at in a bit more detail later on. These are the coronal sequences. Just to look at the anatomy over here, the lateral ventricles, and these are the thin slit-like third ventricle, with either side being represented by the thalami and inferiorly by the hypothalamus over here. Just looking again in the sagittal plane, we have looked at this earlier on. The third ventricle is this space over here running anteriorly almost up to this membrane over here, which is difficult to appreciate on T1, but you can see it on T2. It is this membrane that I'm referring to, which is the lamina terminalis, which is actually the cranial end of the neuropore, which closes during embryology. So this is lamina terminalis, which is here, which is bounded by the anterior commissure, which is here the anterior commissure running all the way up to the optic chiasm. Again, the anatomy is the same we talked about earlier on. This is a sphenoid sinus. This is a optic chiasm, the pituitary infundibulum, the mammillary body. So this is the third ventricle with its recesses, anterior recess over here, just behind the lamina terminalis, extending into the optic chiasm, what we call as a chiasmatic recess, and the one which leads into the pituitary infundibulum. This is a third ventricle with its anterior boundary, with its anterior recesses. And this is a patient with a subarachnoid hemorrhage, actually, just to show you if blood is there within the lateral ventricles and third ventricles communicating via the foramen of Monroe. It can actually extend into these recesses themselves, but also extends via the aqueduct into the fourth ventricle. We talked about this anatomy of the inferior recesses of the third ventricle. This is just to show you the pathology which can affect the lateral wall of these inferior recesses. This is a patient with Wernicke's encephalopathy, patient who's alcoholic with confabulation, and you can see that there is high signal affecting the hypothalamus, which is around about this area on either side of the supraoptic recess of the third ventricle. And the final aspect of the third ventricle to talk about are these posterior recesses, which we'll talk about in detail next week when we talk about the pineal gland. And this area is called as the epithalamus. It deals with the pineal gland over here and the structures which hold the pineal gland together, which is the habenular commissure and the posterior commissure, and the small recess which extends into this pineal gland is the pineal recess of the third ventricle. But we'll talk about that in a little more detail next week. We finish off the third ventricle, two structures in the roof of the third ventricle. So we have looked at the anterior wall, we have seen the floor, and the roof of the third ventricle itself is formed by two structures. One is the fornix, which is sort of a band of white matter running along the roof, and also the internal cerebral vein. So a fornix is nothing but white matter tracks which connect the limbic system, the hippocampus over here, as it swings forward along the roof of the third ventricle. So here we have the fornix, just to show you, this is within the temporal lobes which lie here, the sagittal in the sagittal plane, and the fornix itself has got a posterior column, and then it comes into the body, and then the anterior column. So the third ventricle is residing in around about this area over here. And this is the fornix that we are seeing, and this is a fornix that we are seeing here in the sagittal plane, starting from the back end, coming to the anteriorly, but more posteriorly, it's going to communicate with the temporal lobes before it does that. And this is just to show you the pathology with acute onset amnesia, with infarction affecting the roof of the third ventricle, where you would expect the fornix to be. And other structure that I mentioned, the roof of the third ventricle are the internal cerebral veins. And this is a CT venogram just to show you so this is the corpus callosum over here. This is the thalami over here. And in the roof of those is these two paired internal cerebral veins, which goes all the way back behind the splenium of the corpus callosum and join the venous galen before emptying blood into the straight sinus. So these are the internal cerebral veins which lie here, again showing the same appearance over here in the roof of the third ventricle. So this is a third ventricle over here, the floor, the anterior wall, the pineal recess, and then the roof of the third ventricle with the internal cerebral veins. And this patient has got venous sinus thrombosis, deep venous thrombosis. Look at this appearance, nice linear enhancement of the internal and a very mottled appearance with clot extending into the vein of Galen, but also into the straight sinus, resulting in this venous hypertension and venous infarction of both thalami. And we have seen this appearance of Wernicke's encephalopathy in the patient earlier on. Cerebral aqueduct communicating CSF from the third ventricle to the fourth ventricle, a very thin linear structure over here. We have seen the two colliculi, the superior and inferior colliculus, which is part of the midbrain. So this was our tectal plate or quadrigeminal plate cistern, and this was in the front, the interpeduncular cistern in front of the cerebral peduncles, and this was a prepontine cistern. So that's the aqueduct leading into the fourth ventricle at the level of pons and the medulla oblongata. So moving on to the fourth ventricle, as I said, it lies between the brainstem, the pons, and the medulla, and the cerebellum at the back. It has got its classical appearance where it looks like a tent on its side. And the two sides of the tent here, you've got a superior, what is called as a superior medullary velum, and the inferior medullary velum, which are basically the roof of the fourth ventricle. And the midpoint of that is usually at the midpoint of pons or just below it, and that is what is called as a fastigial point. And it's very important to look at that when you're looking at pediatric scans to understand whether the morphology of the brainstem is normal or not. I realize I've already passed 10 o'clock, so if people wish to stop, we can stop, or I'm happy to continue. What would you like to do? I've got another about 7-8 minutes left.
Continue, please.
Okay, so we'll continue for the time being now. Okay, so you've got the fourth ventricle over here, and this is in the coronal section over here. You can see the sort of a diamond-shaped appearance, and this is an appearance you would see if you're looking at the fourth ventricle from the back. If you have taken off the cerebellum, but on axial MR scan, you can see the appearance of the fourth ventricle, most voluminous at the level of the fastigium, here at the level of the middle cerebellopontines. We talked about the peduncles in the infratentorial anatomy, but as you go more inferiorly, it kind of tapers towards this area, which is called as the obex. And more inferiorly, it's going to communicate, we know, with the via the foramen of Magenti into the cisterna magna here at the back, cisterna magna, and more laterally with the foramen of Luschka to the lateral medullary cistern, with the contained vertebral artery and its branches. Just finally, in the last 5-6 minutes, we're going to talk about the CSF flow, because I think it's important to understand that the cisterns, the CSF spaces, and the ventricles, they house this CSF, and it's important to understand how the CSF is formed and how it circulates. So of course, CSF is formed within the choroid plexus itself, within the lateral ventricles, within the third ventricle, and within the fourth ventricle. But it is present only in the roof of the lateral ventricle and in the occipital horns. It's not present, it doesn't extend anterior to the foramen of magna of the foramen of Monro. So there is really no choroid plexus within the frontal horns themselves. So we've got choroid plexus within the posterior aspect of the lateral ventricle within the roof, but also within the third ventricle. And this is what we are seeing here, this enhancement within the roof of the third ventricle within the lateral ventricle themselves, and they can take bizarre appearances. They can enhance, they can contain fat, they can contain calcium, and only within the posterior fossa they can sometimes actually extend out of the ventricle themselves and project within the cerebellopontine angle system and enhance as well. But this patient also has a tumor related to the choroid plexus. So that said, they can contain calcium, and you can see the calcification here on a CT scan, and also on an MR scan you can see the calcium within the roof of the fourth ventricle, and also extending through the foramen of Luschka into the cerebellopontine angle system. And the reason to understand all of these is because we see clinically patients with hydrocephalus. And this is a patient who's got hydrocephalus, and you can see that the ventricles are much dilated. So instead of having this nice sharp margins, the margins have become much more rounded. Instead of having the white matter which surrounds, the white matter is now fluid filled because of what we call as a transependymal seepage through the ependymal margins, where the fluid has now tracked itself outside. So this patient is the same patient I showed earlier on with basal meningitis causing hydrocephalus. And just next few examples to show again to highlight the anatomy. We've got the lateral ventricles which communicate via the interventricular foramina, the foramen of Monro into the third ventricle, and this patient has got a tumor. So again, the anatomy here, the frontal horns, the midline septum, and this is the foramen of Monro on the right side, and you can see a tumor within the left foramen of Monro causing dilatation of the left lateral ventricle over here. A sequence which is very useful is high resolution T1 or T2 through the midline, which will show you the foramen of Monro colloid cyst as it happens in this patient. Note that the aqueduct and the fourth ventricle is normal in this patient. Obstructions at the level of aqueduct. This is what a normal aqueduct will look like. We have seen this third ventricle ad nauseum today, the thin slit like aqueduct over here. But here you can see how the aqueduct has kind of ballooned out. You can see that there is a kind of a membrane or stenosis at its lower end. But look at the secondary changes that are occurring within the third ventricle. The third ventricular floor itself normally should be pointing superiorly convex, but this is now bulging inferiorly because of the raised pressure. Look at the anterior wall, which should be nice and sharp. The anterior wall, has started to bulge much more anteriorly. The lamina terminalis is starting to bulge, and also the recesses are starting to become more prominent. So this is the floor of the third ventricle, which is bowed inferiorly, and the aqueduct, which is dilated because of aqueductal stenosis. This is a patient with tumor, and the importance to understand the anatomy. This patient has needed a treatment. The surgeons amongst you will know what the treatment has been offered to this patient is what is called as a ventriculostomy, wherein a surgeon would make a hole along the floor of the third ventricle into the prepontine or the interpedunculair system. And this is where it's very important to look at the anatomy, because the basilar artery is so close by in that location and can actually sometimes jut itself upwards into the floor of the third ventricle. And finally, the fourth ventricle obstruction. Here you've got a tumor within the fourth ventricle in the midline and going outside via the foramen of Luschka. This is an ependymoma, and here this is another patient, again tumor which has extended into the upper cervical canal itself via the foramen of Magenti into the cerebellopontine, into the cisterna magna over here. So these patients, 2 patients with ependymomas, just showing how intraventricular tumors can cause obstruction to CSF flow. And finally, before we finish this discussions for today, is a case of, do you know what this pathology is? Anyone wants to type out what the pathology is? Perhaps you can just quickly tell me within the next minute or so. I'll just describe. The cerebellar tonsils are up to C2-3 disc level over here. There is crowding at the level of foramen magnum. The medulla itself has descended way down. This is a pons. The pontomedullary junction is at the level of the foramen magnum. Marked descent of the uh, uh, brainstem and the cerebellum, and a small posterior fossa. So this is a Chiari malformation. And when you suspect a Chiari malformation, it's important to do CSF flow studies. I cannot show you a video, but on basically what you're trying to say is this flow of CSF, whether it is hampered in the midline, in the prepontine cistern, in the upper cervical canal. In this patient, you can see that there is paucity of flow along the posterior aspect, but you should be able to see the midline CSF flow pathways, and it is a CNA study, so you have to something observe whilst you do it. So those are the topics for discussion today, friends. So we've looked at the meninges. We started with the meninges and understood the 3 meninges and the concepts about how they anchor the brain and their important relationships. We have looked at the various cisterns and its contents. So they are not just CSF spaces bland. They contain nerves, the arteries, and the veins, and we have looked at them in various locations. And finally, we have looked at the ventricle, the anatomy, and a bit of the CSF flow pathways and the pathology related to them. So I think I'll stop there now, and I can take some questions. There is a little bit of change next week. I think Dr. Potter was going to speak, I think, but I don't think she can. So I'm going to be doing a discussion on pituitary and pineal region anatomy. So I'll take any questions if you have now. Thank you. Okay, I'll give a couple of minutes, and if there's no questions, I think we can enjoy the rest of our Sunday.